Prognosis hinges on your response to anti-Parkinsonian medications. If you don't respond to levodopa, it's very unusual that you would respond to any other medications. Without levodopa, you saw the curve. Prognosis is worse, mortality goes up. 50% though of patients have none to mild disability at 6 years. That's pretty good, half of you. Half of you would have no disability at 6 years. Only 10% have mild symptoms, however, after 10 years, and only 5% are severely disabled within 5 years. So it's, bottom line, a slowly progressive disorder. Progression is usually stable for each person. In other words, it varies from individual to individual, but if you're a slow progressor, you'll stay a slow progressor. If you're a fast progressor, you're usually going to stay a fast progressor. So this slide is fairly important. In the early stage of Parkinson's, you have mild symptoms, activities of daily life are not jeopardized. You have something called the honeymoon period, where the doctor gives you the drugs, they work quite nicely, you love the drug, you hardly know you've got Parkinson's for, about 5 years, and then you slip into this moderate stage. At the moderate stage, 90% of patients given levodopa anyway develop these motor complications where it takes more and more drug to get the same effect, get the dyskinesia, the non-motor aspects become more of a problem. The symptoms begin to affect those activities of daily living scales. You require more intensive treatment, and it's around this stage that your doctor may begin to increase your medicines significantly and even consider deep brain stimulation, surgical options for Parkinson's disease. Then you go into the advanced stage. Symptoms are more resistant to all forms of treatment. Disability can be quite high. Motor complications, sometimes the motor complications themselves outweigh the Parkinson's disease itself. Freezing becomes more common. This leads to falls. Cognitive decline begins in this advanced stage, and the two unpleasant D words, dementia and death. Mortality in Parkinson's, life expectancy is still close to normal if you treat it right. It's longer in the non-demented Parkinson's patients. It's longer if you use levodopa, but levodopa has these motor complications. It's higher than other atypical Parkinsonian disorders like multiple system atrophy, PSP. The most common cause of death in Parkinson's, again, pulmonary infection, aspiration, urinary tract infections, pulmonary embolism where blood clot breaks off and goes to your lungs. And in my experience, it's more complications from falls and fractures. You fall, you break a hip, you end up in the hospital, you get pneumonia, that sort of thing. But Parkinson's itself does not kill you. Dementia in Parkinson's, we used to be taught it only occurs in about 25 to 30% of cases. It's usually mild. When progressive, it's because you've developed Alzheimer's too. Well, we know that's not true anymore. Because doctors keep patients alive longer and longer because the outlook for Parkinson's is so much better than it used to be. People live longer. If you live longer, you're more prone to get memory and cognitive problems in Parkinson's. The dementia doesn't tend to be due to additional Alzheimer's pathology. It's from Parkinson's itself. But it is different to Alzheimer's. It is milder. It has different features, but it is common. This is Robert De Niro, demonstrated, I think, quite well dyskinesia. But the reason I put this in was when you get frustrated about what doctors can't do, what science can't do for you, remember that that movie portrayed that it wasn't until the 1960s that we could do anything for you. That was when levodopa was found and came into use. It wasn't until the 70s that it was used quite commonly and accepted by insurance. So if you think about from the 1960s to today, and now we have these multiple drugs that we can use, these really fabulous surgical procedures that we can use, we really have come a long way. We haven't cured it, we haven't found the cause for it, but like I was telling you about your grandmother, we have a lot more than we could do for it a generation ago. To understand the treatment of Parkinson's, you sort of have to understand the chemistry of it, and I'm not expecting you to get this, but your doctor gets this. There are various medications directed at all sorts of areas of that little synapse, both the presynaptic part, the postsynaptic part. Most patients with Parkinson's disease require a combination of multiple medications to optimally treat it. You just can't take one drug or two drugs. You might be able to do that in the beginning, maybe for 5 years or so. But treatment of Parkinson's disease is considered multimodality, not just drugs. You might need non-pharmacological therapy. Education is very important, support services like what you see around here, exercise, very important, nutrition. If I have time, we'll go over a little bit of that. So the issue with treatment, which you will always take up with your doctor, is, well, should I treat it or shouldn't I treat it, and when should I treat it? We do know that levodopa somehow mitigates the disease progression. It definitely causes motor complications, but levodopa is still the best drug to treat symptoms, and I use it all the time. I might use it as the first drug in, let's say, a neurosurgeon who needs to keep operating. So the way your doctor uses medications is not going to be the same around this room for any of you. It's going to be hopefully be tailored to each individual case. Like my nurse practitioner keeps coming to me and saying, well, on this 35-year-old patient, you use this drug for the first line of treatment, Azilect or something, and on this 35-year-old patient, you use dopamine agonist. What are we supposed to use on a 35-year-old patient with newly diagnosed Parkinson's disease? The answer to that is there's no cookbook approach. We can't have a cookbook approach because you're all individuals. You have different jobs. You have different needs. You have different concerns. We have to tailor it to you and the side effects of the medication and what you need right then and there. There's some disagreement in doctors about when to start levodopa. I use it when we need it. Just really briefly, risk factors for developing these motor complications. If you use high doses of levodopa, your risks for developing go up. If you use levodopa sporadically, like a whole lot, Monday morning and then none on Tuesday, risk factors for motor complications goes up. So the treatment mentality with patients usually falls into, no one is the boss of me, I'm not going to take any medicines till I'm good and ready to, and I'm going to figure out how to do it by reading the internet. I'm not going to listen to anyone, my family, my doctors, no one. Or on the opposite end of it, okay, you're the boss, I'll just do whatever you tell me. I don't want to be educated about it. I don't know why you're doing it. I just want you to do it and don't tell me about it. But I feel like we should kind of have an in-between. You know, let's make a deal where you trust me to do what's right for you, but I need your input about what you want to do. So we have a partnership with my Parkinson's patients that